Slido. Raise your hands if you're having any issues accessing Slido, because we can do it a different way. Day-to-day life working for the Ncaa. Yep, I can talk you through that. I think you can also use this barcode thing. If you point your phone at the barcode, that might just get you straight there. Okay, I'll give everyone till just after 10 past, so you've got a couple more minutes just to get your head around this new technology if it's new to you. My own experience, yep, I'll try and throw a bit of this. How long have I worked with the Ncaa? Since 2017, so kind of as it formed. I can say it's changed a lot in the last couple of years in terms of what it's like to work with the Ncaa. I never thought I'd work from home, but I do. So we're 18 people on the call and I've got 8 of you on Slido. Let's get to halfway and then we'll move on. If half of you are on Slido, I can move on. So you put slido.com into your search engine. It'll ask you for a code, which is 233730. And then if you press on the polls bit, polls tab, it will then ask you this question. Okay. So I'll try and weave those questions into the rest of the presentation. So we're now going to do a quiz bit. So you're still using Slido, but we're going to use the quiz section. So you should now see in on your polls a question: how many people work for the Northern Care Alliance? Is it 800, 8,500, 18,500, or 88,000? Just take a guess. So we cover Fairfield General, Salford Royal, Royal Oldham Hospital, Watchdown Infirmary, and then we've got community services in all those places as well. So you've got the big tertiary centre at Salford that looks after neuroscience, so that's like spine, brains, takes all the big trauma from Wigan, Bolton and Salford. Oldham is a kind of, don't have a scoop, so just have a guess. I'd say most of our staff will do the same. Ellie, just let you in. Ellie, welcome. Okay. So we actually employ, if this works, we actually employ 18,500 people across those 4 sites. So we're a big old organisation, and I guess that's the first thing. What's it like to work with the Ncaa? It's really different. There's, depending upon what you do, we reckon there's probably about 350 careers. You never get to know everybody, but we're all hopefully friendly. And there are so many different roles, from direct healthcare roles to engineers to cleaners to people like me who have management positions. to comms and digital, to our IT people. So we're 18,500 people. We're growing all the time. We're probably in the top 10% of large NHS organisations. Okay. So that's your scoreboard and how quick. So there is also a scoreboard to who gets the quickest and if you get it right. So if you haven't yet joined Slido, please do. Just use the slido.com and the codes there. So how much money a year do you think we spend? Again, just have a Scooby-Doo guess. £1 million, 100 million, 1 billion, 1.3 billion. So this is all money that is generated by taxpayer. So we get all of our income via tax. We get an annual allowance from the government. We get paid some situations for block contracts, regardless of how much activity you do. And then we get money per piece. So for like operations, you get paid per operation you do. We get a tariff for like every A&E attendance, and then other activities we just get a block amount. I think it might have coming up with a colleague from finance who's probably going to go into that in a bit more detail in terms of how all the money goes around. We get money from the 1st of April to the 31st of March, and if you don't spend it by the 31st of March, it disappears and goes back to the government. So our financial regime's quite interesting. So 10 of you have had a guess. Okay, I will. We actually have 1.3 billion last year, and that is excluding any of our COVID costs that we got in via different routes. So that's kind of our average. Roughly 75% of it is pay. We also have big capital projects. So those of you who drive for may have seen Salford. We've got a big build in Salford. We've got 2 big builds in Oldham at the moment. They're building a new ward. It costs about £1 million to run a ward, roughly. And then big spends on things like big pieces of kit. Drugs is another big spend. But I won't say thunder from any financial colleagues who may be in talking to that. So, okay. Fee, you've jumped to the top of the leaderboard, having got both questions right. Okay. So the Northern Care Alliance was formed in April 2016. So Salford Royal was a separate organisation, but in 2016 it took responsibility for services for Oldham, Bury and Rochdale. So we created what we called initially the Northern Care NHS Group, and then in October last year we became the Northern Care Alliance NHS Foundation Trust. The Secretary of State is the only person who can, Secretary of State for Health is the only person who can change organisations, so we had to go through a process to do that. We've got the 4 hospitals that I've talked about, our operational budget. In terms of population, we look after about 1.2 million people, and we've got 4 care organisations, so each of our places have got a care organisation. That's how we're structured. We have staff who work in, say you work in Oldham Hospital or in Oldham Community Services, you come under Oldham Care, and then we have group functions for things like estates, finance, IT, and we cover them all. So each care organisation has a medical doctor who provides medical leadership, a managing director who's responsible for the day-to-day services, running of services. We've got director of nursing who leads on quality and governance, director of finance who keeps an eye on that 1.3 billion, a director of workforce because we recognise that workforce is one of our key delivery areas. And of those, that team, one of those directors is a chief officer. So I joined in 2017 as chief officer for Oldham, and was also the managing director, so I had responsibilities for the day-to-day running of the site. So I joined the health service 20 or 25 years ago. I don't have a clinical background. I came in as a graduate from the graduate training scheme, so I've actually got a history degree. Not quite sure how history degree ended in here, but just shows the different ways you can come in. I worked through a variety of roles, which included working in Merseyside, and became a board director. So up until 2019, I'd done day-to-day running of hospitals. So it is everything from the generators packed in, to staffing, to managing budgets, to managing staff. And then as we go and talk about it, I took an opportunity to kind of step away from that and to really think about social value, which we'll now go on and talk about. If anyone's got any questions, just either stick them in the chat or raise your hands, and we'll see where we get to. So just thinking about, so we provide health services. What do you think contributes to a good and healthy life? So in this one, if you're still on Slido, it's asking you for words. What kind of things mean people have a good and healthy life? Now, I know some of you are health and social care students, so I'm hoping you'll know this. What do you think? If you can't get on Slido, just stick it in the chat. Happiness, mental well-being. Exercise, yeah. Balance, that's a good word, balance. If there's a word on there that you agree with, just type it in as well, because it makes it go bigger. So for colleagues who are just joining us, we're using Slido, which is you can either do it from your phone or open another page on your computer. You join at slido.com, asks you for code, which you just pop in, and then you should be able to join in this chat. If you haven't got access to another device or struggling, just stick it in the chat. Right. So if we look at a good life to be your length of your life, so you live to a ripe old age, and that you have a quality of life in terms of ability to live your life pain-free, etc. What we know is that 30% of that is driven by health behaviours. So that's as you talked about, diet and exercise, tobacco, alcohol and drug use. Only 20% of that is actually to do with health services, i.e. the timeliness of treatment, the quality in terms of indicators like waiting times or nurse ratios, etc. 40% is actually to do with social and economic factors. So have you got good education attainment? Are you in employment? So there's really strong links between good employment and good health. Do you have strong family or social support? So we know during COVID there's been issues around social isolation and people feeling vulnerable. And do you feel safe? So do you feel safe in your own home, safe to go outside and to walk? And 10% is around environmental factors. So that does include housing, so in terms of do you have a warm home, but it's also increasingly things like there's big debate in Greater Manchester at the moment around the air quality zones, around supporting our wonderful planet in terms of sustainability. So 10% of the physical environment will impact on health outcomes. So health is driven by policies and programmes, which are usually driven by our experts and taken on board by our government, health factors, which then lead to health outcomes. Does that surprise anybody? Does anyone have any questions? You're all just being quiet. Stick them in the chat, put your hand up. Be nice for someone to speak. Olivia, you were first to put something in the chat. Is there anything that surprises you from that diagram? Olivia's gone quiet. Is it unfair to pick on you? Oh, you're being quiet. I'll just move on. Oh, hang on. Yes, you do. So, would have thought that health factors would be a higher percentage. Yeah, a lot of our staff thought that. A lot of our staff thought that clinical care would have a higher priority. It's the social and economic factors, which is the 40%, which is surprising and makes you think about what we do in terms of to support education and employment. Okay, so this is a quote from our chief exec, Raj, who has retired, and Owen, who's taken over him, shares the same sentiments, that says we can't just think about what we do to care for the sick. We need to think, particularly of what COVID has shown us, about what else we can do to contribute to that 40%. So if we think we employ 8,500 staff, we've got a spending power of 1.3 billion. How we spend that and who we employ will have significant impacts on the health and well-being of the communities that we serve. So what happened was, in 2019, as I said, we get policy and documents that kind of feed what government direction is. So we had the 5-year NHS plan, and the final paragraph of that plan said NHS organisations should consider becoming an Ncaa institution. Also in 2019, the Health Foundation, which is kind of one of our leading kind of think and research organisations based in London, but it's got a national presence, they produced a report that said what is an NHS Ncaa institution. So you'll find that I use the word social value and Ncaa institutions kind of interchangeably, and that's largely because I don't like the word institution. I kind of thought we'd moved on from providing care in institutions, but it's a personal thing, really. And so really what that says is, think about that power you've got from an economic point of view. What if we were to shift some of the spend that we have away from perhaps overseas or national contracts, and think about how we can purchase locally and support local firms? What if we were to open up our buildings and our support and our spaces for community use? The NHS, as it says there, occupies over 8,000 sites and 6,500 hectares of land. Now, I know COVID's put a bit of a damper on that because we haven't been able to open up our buildings, but just to think about what if we were to use that space differently, particularly when you think of things like our lecture theatres, our grounds. What if we learnt and worked more closely with local partners? So it's stuff like this, reaching out to our FE colleges and think about how can we support each other. So how can we talk to you about careers in the NHS, and you can come and be one of our 18,500 employees in the future. But also you help us think about actually how do we engage with young people. Environment is a massive, we are a massive polluter, we the NHS, and the NHS generates 40% of public sector carbon. That's probably got higher when you think about all the masks and everything we've had to wear during COVID. Perhaps the biggest one is around, Emily's saying her chat isn't working. You can put your questions in Slido, or you can just stick your hand up. It won't open for you either. My apologies, that doesn't help then. Yes, use this Q&A and put your questions in there. I thought you were all being quiet. So access to work is one of the big things we can do. So, so in terms of an anchor institution, so an anchor institution kind of came around about the 1980s. It's a concept from America. It says they are large organisations that are going to be here forever. So a hospital, it may change its name and we'll change our configurations, but we know we're going to be there. And we have links to the community, so we have clear connectivity to place. So my role was to kind of step out of the operational running of Oldham Hospital and to start thinking about what does that mean for the Northern Care Alliance, particularly if we think that some of the communities we work with include some communities with really low income have got high amounts of poverty, high disease, and really how we can think about what else we've got other than just the role of caring for the sick. So we created what we called our social value mission, which is the deliberate and purposeful use of our people to support the economic development place. So my role sits within group, but we really deliver this in each of the places. And we've got different work streams. So we've got our environmental, so how are we hitting the greener NHS in terms of reducing of carbon, reduced car parking, think about what anaesthetic gases we use, the inhalers that we give out to patients who are asthmatic, can we do that in a way that's more environmentally friendly? We do a lot of work in place, so thinking about our four localities in terms of how do we really think about how do we support those who've got real structural inequalities. And we know the pandemic has really shown structural inequalities in terms of how different communities have fared during the pandemic. We know, for example, that young people getting to work, it's got a lot harder because of what's happened over the last two years. So what are we doing to support you? People, again, we set ourselves a really clear target to increase by 5% the number of people we employed locally by really being really clear what are the ways you can get into work, and I'll talk about that a bit more. And we've also agreed to increase our local spend by 10%, really thinking about food. So how do we buy our food locally? Social care, so we actually are a commissioner in Salford and Rochdale for social care. And also really thinking about our capital scheme, so our big capital programmes, how do you make sure that the builders are local? How do we kind of use our local trades for that? And then the final bit is around how do we really support the national debate? And I think during COVID, post-COVID, whatever term we're using is where we are now, how are we really thinking about sharing that learning in terms of really how do we connect this to our equality, diversity and inclusion agenda? And how do we really reach out to members of the community who to engage with? And how we do that is twice a year we bring people together like this. There's usually between 60 to 80 people on a call, and we do a community practice where we debate, we challenge each other, and we come up with what's our next strategy. I'm just going to check that Ellen's put a question here. No, just feel free to add your questions in there and into the Q&A of the Slido. So we are the biggest employer in Oldham, Rochdale and Bury, and one of the largest in Salford. We know that at the height of the pandemic, a third of all available jobs were in health and social care. We know we talked about that decent work supports good health. So what are we doing? So we set ourselves an ambition that by 2025 we'll create 1,000 pre-employment opportunities every year. And we'll really focus on those who are further from employment. So we think about working with the Princess Trust for young, who aims at young people up to 30, who may have barriers. They may have had periods of homelessness. They may have been in care. They may have dropped out of school. We also work with, for example, we've got a scheme with the Proud Trust where we reach out to members of the LGBTQ+ community. We've got a programme that is specifically looking at Asian women and our Black and minority and ethnic communities. So we're trying to look at how do we create a pipeline and a pathway to say how do we take those skills and inclusion that's in those communities and how do we bring them to our organisation. We want to have move from 45% to 60% of our people will be local, and we wanted to have 1,000 NHS career ambassadors and work experience hosts. So they are people who will be able to come in and talk to you guys, who can have work experience, and at the moment that's all online, but in terms of over time as COVID restrictions lift, how we can bring you in exposure to the world of work. So kind of why did we do that? So you may have seen a kind of cartoons like this, and what it kind of says is, if we think the narrative around Ncaa institutions is about how do you use your economic and social power to kind of reach into that 40% that drives health outcomes. So what we try to think about in the world of work, how do we move from a narrative that says we want the best person for the job to how do we use our employment power to address the underlying determinants of health, like employment, poverty, and how do we use those powers to support the health and well-being of our population. So I hope that we're not in a place where jobs like apples just land in your lap. So we've moved on from an inequality space to perhaps a place that looks at equality. So we will say we stick a job advert out, there's a job spec and you apply, but we still know that still doesn't distribute the tools and assistance equally. The apple tree in this one is all loaded to the left hand side. So an equitable approach to this is that we do recognise that some colleagues may need an extra couple of ladders onto that, a few more steps on their ladders. So it may be that we've got young people through the support internship programme who may have a learning disability. So we have specific programmes to think about how we can bring them into the workforce. But a social justice approach to this will kind of say we need to change the system, and we need to think about whether or not sticking a job advert out is the best way of getting getting people into our level entry jobs, into the first step jobs. So get ready for your live quiz. So just by way to illustrate some of that, what percentage of the neurodiverse community do you think are in full-time paid work? So do you think it's 7%? Do you think it's 17%? A few more people. Do you want to just work 9 out of the 14 of you in there? So neurodiversity includes things like dyslexia, autism, Asperger's syndrome. So a good mix. 40% for 17, 37 and 37%, 20% at 17, nobody at 7. The answer is 17%. So 17%. So according to the UK neurodiverse survey that was done, 17%, despite 77% actively looking, i.e. they are putting applications in. We know that the neurodiverse community bring a whole set of skills, so ability to great ability for detail, extremely loyal colleagues. So when I first wrote the first board paper for the Ncaa on this, I had done that classic where you'd ask people to comment on a paper and then got completely confused over who had done what. So I ended up doing that old-fashioned, you can tell my age, printing off 4 different versions of the one same document to try and track on a table where people had put comments in. And I met a colleague called Patrick who showed me within 2 minutes how to do it on the computer. I'm sure you're all dead techie and you know how to do track changes and merge documents. I didn't. And we got chatting, and Patrick is a member of the neurodiverse community. So he came with me to the board and he shared his experience in terms of what skills he felt he had. And what he said to the board, which was that, you know, we're all human and it's about finding the skills, and his attention to detail, his technical knowledge, particularly around IT, was off the scale in comparison to certainly what I could do. And so it is in terms of what he brought to the organisation, it was fantastic. So Fee is still top of the leaderboard. Okay, let's just think about another community group. So if you were to apply nationally to the NHS, what's the likelihood of a member from the white community being appointed from shortlisting? So you've been through the first sieve, you're at shortlisting, to colleagues from the BAME community. Just give you a few seconds more because I want a bit of time for questions at the end. Yeah, the answer is 1.6%. So we know that we have more work to do around how do we encourage different communities to kind of come work within the NHS. So within the Ncaa, we've adopted a number of policies around our inclusion agenda. So we are clear with managers that if there is a colleague from a underrepresented community who applies, that we want to know why they aren't shortlisted and why they weren't successful. We've got specific programmes to support colleagues. We've got staff networks, so for LGBTQ+ colleagues, for our Black and Asian minority ethnic colleagues, and for our disabled colleagues. And we also have mentorship in order to support those colleagues through there, doing recognition that even within our own service, we know that there are structural issues that we need to address. Oh, Fee, you've been knocked down to 4th place. And Rachel, you have won with the hardest question, the Ncaa annual budget. That's interesting. Okay, so what's happened since we've done this? So despite COVID, and we had real restrictions on who we could bring on site, we weren't allowed visitors. Last year we've created, it was 421 COVID compliant pre-employment opportunities. That includes some of you guys who might be doing the cadet programme, with specific targeting of those furthest away from employment. We've changed our internal process, so if you're on a pre-employment learners, we are encouraging you on the way to get into paid work part-time whilst you do it, or if you're one of our shorter courses, we will guarantee you an interview. So those of you who are cadets and you want to go into work following your T-level, we will move you into an interview. If you want to go on to university, we'll have conversations about, do you want to do something part-time in the meantime? So we have moved our 2025 target, which was 5% to get to 50, because we're now at 58%. So we're now aiming to get over 60 by 2025. And our staff coming forward to say, despite the pressures and despite COVID, I'm really willing to go and talk to young people about what it's like to work in the health service. We're at 800. So that concept of what is our narrative in terms of we're using our economic and social power to address that 40% that drives a well-being and health outcomes. Looking at our data, so we constantly look at where do our staff come from, what's the outcomes for those staff, how do they feel in terms of staff surveys, look at that by location, and then go and talk to those community groups and look at pre-employment changes. That's led to a series of actions, which I kind of talk through some of those, and that's what's given us these changes. So here are a few examples. So the first one is a learner who's from 2017 who came on the Princess Trust. So this is a young woman who had very little qualifications, but did a a pre-employment opportunity through the Princess Trust with us, did some work experience in our recruitment office, but really wanted to go into care. So she actually went back part-time and did college work, and has now gone on to university to be a nurse. What's also remarkable about this young woman, she's registered blind, so she managed to do all of that and work. We've got a learner from last year, so this is from one of our programmes in Oldham. So this is working with Positive Steps, which is a youth organisation, who is a young woman who's a carer, so is a main carer for a dad who's got severe medical issues. So she didn't have great qualifications from an education point of view, but she knew healthcare because she'd supported her dad. So actually we were able to take those skills, and she's now got full-time work with us. On the bottom is really from a manager's point of view. So Lucy is a colleague who has additional needs, but has an amazing concentration error rate. So there's a role within pharmacy where you check drugs. Most people have a natural error rate of up to about 5%. Lucy's is less than 0.5%. So we might have to make some minor adaptations in terms of Lucy's hours, etc. But actually, she's a brilliant colleague and has found a role that suits her. We also have so biomedical sciences, so the labs. Historically, we have a turnover rate of a third, so about a third of staff who work in that just turnover, and that's largely because graduates want to come in, want to get some NHS experience, and then they might go and work in industry. So it's really difficult to get some stability in that workforce. So we're now actually using the Princess Trust to find young people, and then we balance that against the graduate. So it kind of works from both sides if you take a much more kind of social value approach to just sticking, rather than just stick out an advert. So we know for those individuals and for us as an organisation, we have supported people into employment who may not necessarily have got into employment, that therefore their health outcomes, and particularly those for their families, will be greater. So as I said, we bring people together twice a year, and I've only shared 4 stories, but if you times those up by the size of our organisation, we really could really make a lasting difference to the economic and social outcomes from our populations and our places by thinking about how do we use that 18,500 staff and that £1.3 billion spend. So I don't know if you'd ever have to do an essay on this kind of thing, but here are some links and for some further reading. You might have heard of Professor Marmot, who did some of the first work across Greater Manchester about health inequalities, the Health Foundation report that I talked about earlier, and then the Centre for Economic Strategy kind of has some more of the theory behind how do you lock more public sector spend to place. Here's my email address. We've got a Twitter handle, and if you want some more information, just let me know. Hopefully it won't be that too long till we'll actually be able to get you on site and see you in person. But in the meantime, we've got about 10 minutes left for questions. If anyone's got any, switch your camera on, say hello. That'd be great.
Thank you, Donna. If anyone has any questions, go ahead.
So Fiona, you put in the chat about the employee set project. Does anyone want to talk to me a bit more about what that is and how we could help with that? While you've got me, has anyone got any, what is your official job title? So my official job title is Director of Social Value Creation. And I have a leadership and management position. So after university, I did a master's in leadership development, and I've done a series of different leadership courses throughout my career. A lot of managers come from nursing because it's one of our biggest profession, but there's also a lot of us who came into the health service either after school or after university and have come through an administrative route. So I may have started life as a medical secretary, working in the booking and call centre, and then worked way up through internal promotion. But because I come from an ops background, there's pretty much not a job that I don't know about, because I've probably come across it. So if anyone's got any more career type questions, just shout out, and if I don't know, I'll know somebody who will and could probably put you in touch. Oh, so the ESP is an extended piece of work, involves a patient role play. Yeah, that would be really handy to think about doing that from a social value point of view. You've all just been very polite.
Just a reminder, you can put your questions in Slido as well.
What did I study at uni, Emily? I actually did a history degree. So I did a history degree because I liked history. And at the end of that, there was a series of kind of graduate recruitment that you could do. I knew I didn't really want to work in industry. I wasn't really that motivated by money. So I looked at quite a few different jobs around voluntary sector, local government. But I actually did an A-level in politics, and at the time that I did my A-levels, I did a extended piece of work, sounds like your ESP, where I looked at the changes to health policy and kind of got really interested in that. And then whilst I was at university, I did quite a lot around volunteering around student welfare. So it kind of was a bit of a natural move from that, but I work with colleagues who've got maths degrees, music degrees. The thing with the NHS is you can go in at any point. You can go in at 16, you can go in at 18, 19 after your A-levels or T-levels, or you could go in after graduation. There'll be those of you on a call who've always wanted to be a nurse, and sometimes I was jealous of my colleagues who from the age of 3 knew they only wanted to be a nurse. So it took me a little while to figure out what I wanted to do, but I've had a brilliant career and I would fully recommend it, but not many people think about becoming a manager in the NHS. Any more questions from anybody? You really want to be a midwife? So there are other ways of getting into midwifery. They're not as well trodden as a historic university degree, so I'll be really honest, most of our midwives, but I will say my mother was a midwife, so so the other pathways are you would join as a healthcare support worker, and then you would train in-house. We offer across the Ncaa at the moment only about 10 TNAs a year, so they're trainee nurse associates, and then from then you would then become an apprentice. So although an apprentice route is really well embedded in some parts of the NHS, in nursing it's still relatively new. So I will be really honest, getting into university is probably the easiest route to become a midwife at the minute. But there are other roles other than midwifery, so our healthcare support workers are a real critical part of that workforce as well. I don't know if that helps, or if you want to come back or switch your microphone on and talk me through about why you're worried about getting into university and what else we can do. So the Northern Care Alliance has maternity services at Oldham, so that's probably the place you want to think about maybe getting in contact with the volunteer office and offer to volunteer, and try and get some work experience or exposure on maternity or children's services. If you can't go through that route, thinking about contacting some of your local creches, after school clubs, those kind of things where there are just families around. And if all else that fails, babysitting, looking after your siblings, that's all brilliant experience. But don't undersell yourself. We need people like you. And if you are worried about going to uni, we're also in conversations. So with Berry College around certainly the adult nursing being on your site so that you don't actually even have to physically leave Bury. You could do year 1 of the Salford nursing at Bury, and then you do year 2 and 3 at Salford. We're really trying to push that to say that not everybody wants to go away to university, and that actually if there's an option to stay at home, carry on living at home, and going to a more local uni that may have be run out of our local colleges, we're really pushing for that. And those of you who do go on to do university study, I know a lot of people work in bars and restaurants, but really think about joining the NHS. We've got NHSP, which is like our internal bank, so you can each week decide how many hours you want to work on. Again, that just gives you more exposure to where we are. So look out for that as well. Right, in the 6 minutes we've got left, any more questions? Anything you want me to clarify from the presentation?
Anyone at all? I think they've all gone quiet.
Yeah.
Well, if let me just check Slido in case there is anything. Not that I can see on here.
No.
So yeah, she's got Emily's question there on the last one. Oh, hang on, is that somebody? Oh no, okay. Right. So if nobody has any questions, thank you very much for all being here, and thank you, Donna. The bit I caught, that was very interesting. So thank you for being here and sharing all that with us. I'm sure we'll discuss this in lessons as well, if we need to. So thank you very much. We'll so the rest of you, thank you very much for coming in today, and I'll see some of you tomorrow and some of you on Tuesday. So.
And you've got my email address if you've got
Yes.
any questions that you didn't want to raise in front of everybody. And Emily, if you want to drop me an email, we'll see what we can do about introducing you to Oldham.
Yes, I mean the midwifery is notoriously difficult from a degree point, but it isn't impossible, especially not for T-level standard students. So
No. And we are really desperate for midwives. It's one of the largely because a lot of people go into midwifery want to then go and have families. So actually, you know that we have lots of part-time flexible in there because people combine it with motherhood naturally. So yes, don't give up your dream, Emily. Just persevere.
okay, well, thank you very much. That was all very interesting, and that's we'll call that a finish then. Thank you very much.
Thank you.
Somebody else commented. Thank you from me. Yeah. I'll give them a chance to say thank you in the chat.
Yeah, no worries. It's always hard when you're doing it online as to whether or not things are landing or.
Well, yes. Oh, they're all gone now. I think, or mostly gone. I'll stop the recording. Yeah. Okay. Thank you very much. Bye.
Okay, thanks, Fiona.
Bye. Well.
Bye now.